Hey everyone, it is 12 o'clock, so we'll go ahead and get started with today's presentation. So thank you all for joining us today. My name is Rachel Flores. I do have some good news to share. This is the final session of the series, of the six-part series. So it will be renewed next year. I'm not sure if we can continue on the same platform, but I do have everybody's emails. So I will send out more information whenever that becomes available. But this series was created to support clinicians with continuing education, telementoring, and collaboration opportunities, and to increase the quality of care and support for persons living with dementia and their caregivers in rural communities. Today's presentation is From Knowledge to Action, Implementing Change in Practice by Dr. Leslie Rosenstein. She is a licensed psychologist and is board certified in clinical neuropsychology. She is a neuropsychologist and Parkland Psychology Internship Rotation Director at Parkland Health and Hospital System, Behavioral Health Clinic Department of Psychiatry at UT Southwestern Medical Center in Dallas, Texas. Before we dive in, I want to take a moment to thank the organizations that make this program possible. This program is supported by DSHS and is operated through the F. Murray Hall Institute for Rural and Community Health at Texas Tech University Health Sciences Center, and is operate in partnership with the Garrison Institute on Aging. So before we dive in, I'd like to take a quick roll call. So everybody, if you can, please drop in the chat where you're joining from today. And following today's session, you will be prompted to complete a post session survey. And then we will also have a post series survey. So if you have completed at least like more than one, please complete those as well. Those will help us as we develop the next series. And CME credit is available for today's session. So I did drop that in the chat. So please make sure that you download it. And then at the end of the presentation, we'll have a QR code as well. Please make sure to mute your microphone, and there will be an opportunity at the end of the presentation for questions. So with that, we'll go ahead and hand it over to you, Dr. Rosenstein.
Thank you. Okay, whoops, there we go. Can everybody see my screen okay? Okay, great. So thank you for having me here today. I'm going to be, well, there we go. I'll be talking today about, I'm a little too far, the diagnosis and identification and diagnosis of dementia. And I'll also be discussing support for patients and their caregivers. So patients can present with cognitive changes, including memory impairment at any age, and these changes can be the result of an abrupt condition like a TBI or stroke, or they can come on gradually, such as with neurodegenerative conditions. Sometimes these conditions are reversible, so it's really important to catch them early and to gather as much data as possible to understand the underlying conditions. So as a provider, our roles may be to become aware of the disorders that may be occurring. And you may notice through observations, such as during an appointment with a patient, that they're forgetting parts of the conversation you've just had, or they may not be following through with your recommendations from one appointment to the next. Caregivers can sometimes reach out to you and let you know that their family members having problems. Sometimes patients will report that as well. And you might also implement regular screening measures like the MoCA or MMSE, SLUMS, or just some brief measure that you can start using at an age that you designate, and watch for changes over time. Once you become aware of a problem, you might refer the patient, consult with others, order labs, and order imaging. And I know here at Parkland, when we want to refer to neurology often wants to have imaging done first and labs before they'll schedule a patient, just because of scheduling issues. Once you know a diagnosis or have a set of diagnoses, you'll be reviewing, or will be, you or any provider will review these findings and recommendations with both the patient and the caregiver. And there are resources you can provide. And I have some of them listed in the corner here, but I'll be going over these again at the end. So don't worry if you don't get them all down and you want them. So when changes are present, one of the things we're worried about is dementia, but we also might be seeing depression, which can present with cognitive changes. And unfortunately, normal aging will get us, and changes start occurring with memory pretty young, as early as 30. I always tell people, but we get wiser with age. And also as people get older, there's more on their plate. So some people will some of your patients will be concerned about cognitive changing, and in many cases it's normal life, normal aging. Patients may be experiencing medication effects, and that can be from prescription medications, but also over-the-counter meds. And then you'll be looking out for deficiencies such as B12 deficiency, and then things like thyroid dysfunction, sleep apnea, or other sleep disorders can cause cognitive changes, and many other things. And when we make a diagnosis as specialists, we usually say consistent with, or probably, or possibly, because many of our diagnoses can't be confirmed clinically. So when we're concerned about dementia, there are different ones that we're looking at. Alzheimer's is one of the more common ones. And the early presenting features will be memory impairment. Patients may complain about word finding difficulties, and they can also have visual spatial deficits. So those are a little bit harder for patients to characterize. And mood symptoms can occur pretty early as well. Vascular cognitive impairment or dementia is actually pretty common, especially in our setting where a lot of our patients have diabetes, sometimes not well controlled, and high blood pressure, hyperlipidemia. Diffuse Lewy body disease and other alpha-synuclein conditions, Parkinson's with dementia, and diffuse Lewy body dementia are becoming more widely, people are becoming more aware of those. Parkinson's, of course, we've been aware of a long time. But with diffuse Lewy body dementia, you'll see REM behavior, so walking, talking, and sleep, visual hallucinations, hour-to-hour fluctuations, and the Parkinson's features. Frontotemporal dementia is another dementia that we always have high on our list of differentials. And there's the behavioral variant, the language variants, and the motor variants. And then normal pressure hydrocephalus, where you'll see incontinence, urinary incontinence, a wide base gait, and some wobbliness and cognitive changes. And in any case, in any of these, a patient can have more than one. You can have mixed dementias. And that's definitely the case with normal pressure hydrocephalus. So the normal pressure hydrocephalus may be treated, but you've still got, there may be another condition underlying them. You can have dementia from alcohol, including alcohol-related dementia, Wernicke-Korsakoff, which is related to deficiency, not just in people with alcoholism. The Wernicke is the acute phase, and once that's treated with thiamine resupplementation, patients can be left with the Korsakoff syndrome with memory impairment. And Machiavelli-Bignami disease, which is a rare condition, it's also a deficiency affecting the corpus callosum. And I keep mentioning deficiencies, so I've talked about thiamine, and there's B12. Multiple sclerosis, we don't always think of as a dementia, but it can progress to dementia depending on the type and the treatment. But it's another differential to keep in mind, especially with some of our younger patients reporting cognitive changes. And then Huntington's, which is, we consider, a lot of, when you think about Huntington's, you think about the motor symptoms, but people can present actually with psychiatric symptoms, and they also have cognitive impairment. And usually it runs in families without skipping generations because it's an autosomal dominant transmission, but you can see sporadic cases. And then there are several others that I haven't mentioned, like infectious diseases, including HIV, neurosyphilis. There you can have autoimmune encephalitis, prion diseases, posterior cortical atrophy. Our patients may have tumors or metastases, and then different metabolic conditions can lead to dementia. So sometimes lifestyle can be addressed, and there are reversible causes of dementia or cognitive decline. It's real important for all of us to be aware of those. With our patients with normal aging, it's helpful to normalize some of the symptoms they're reporting, but also encourage healthy lifestyle activities. Sleep apnea sometimes goes underdiagnosed, or people don't become providers aren't aware of it because patients don't spontaneously say, hey, I snore, choke, hold my breath. But it can definitely cause cognitive impairment, mood disorders, and or depression in particular, and also all kinds of medical conditions that can secondarily affect the brain. Sleep apnea can be treated with CPAP or BiPAP, sometimes with mouth appliances, sometimes surgery or devices, and sometimes patients can be encouraged to sleep on their side if they're able to. And then other sleep disorders may be disrupting sleep, or if somebody has narcolepsy, that's going to appear as a cognitive impairment too. And so you'll look at sleep hygiene, and this is something that we can all address and hope that our patients follow through with, but we want to encourage a regular bed schedule, going to bed at the same time every night, getting up at the same time every morning, restricting time in bed to less than 9 hours, because we know that 9 or more hours is unhealthy. And if people are complaining they're having trouble falling asleep or staying asleep, they may need to spend less time in bed. And then similarly, we want them to limit their nap durations during the day. If they're sleepy during the day, encouraging sunshine and brief physical activity can be good. And then, of course, restricting electronics and including TV. A lot of people feel like they need TV to relax and go to sleep. I'll encourage them to use apps on their phone with their phone facing down, and I explain the impact of the blue light on melatonin production. And then no, don't forget over-the-counter medications, and then their PRN medications. So some patients are taking first-generation antihistamines either on their own or in combination medications like a NyQuil, or they may be taking over-the-counter sleep aids. And those drugs are heavy in anticholinergics, which can affect the brain and memory. Some patients have PRN pain medications and muscle relaxers, and you may prescribe, 4 times a day as needed, but a lot of patients, if you ask them, they're just taking those meds 4 times a day, every day. And you'll be aware of that when they run out of prescriptions, but it's good to counsel patients to take those as they needed, but not necessarily continuously if that's not needed for them. And then substances, marijuana can cause memory impairment, so specifically the THC. And then alcohol, people believe that alcohol is good for us, and there's been some literature on that, but excessive alcohol definitely is not good for cognitive functioning. And then look for deficiencies, and you may want to prescribe supplementation, keeping in mind that some patients won't absorb oral supplements. Look at diet, especially if you have patients who are vegetarian or vegan. And if they are not absorbing, look at underlying causes for their absorption issues. And then cerebrovascular risks can be managed, and so you can slow down the effects of vascular cognitive impairment by encouraging exercise. And I know all of physicians regularly do this. Some of our patients need very concrete instructions, this many times a week, this long, and then they may benefit from having recommendations about specific activities. And of course, any recommendations you have for them for managing their cholesterol and their diabetes with their diet. And if they are abusing substances like nicotine, you can offer treatment for quitting and referrals for alcohol treatment. And then patients have trouble managing their medications, so you might want to talk to them about calendar pill organizers. There are monthly ones, weekly ones, twice daily, 3 times daily. And there are also pill dispensers that they can use, calendar rate locking automatic pill dispensers. I usually recommend that people use their pill organizer in combination with an alarm on their calendar phone app. And some people find that helpful. A lot of our patients are very inactive, and so we'll encourage social and intellectual activities, and I'll be very specific about ideas. So I'll brainstorm with them, or I'll pick up on things that they say that might give me some ideas about their interests. But there may be senior centers in your area, volunteer activities. Some patients will say they don't like being around people. So then I talk about, well, animal shelters need somebody, or if they're a member of a faith-based organization like a church or a mosque or synagogue, those organizations may have volunteer opportunities, and they also may have activities throughout the week that your patients can participate in. Again, be really concrete about the physical activity. And if you have handouts, I think those are great. Physical therapists are known for handouts or links to videos for exercises like chair exercise videos set to music, a list of indoor pools that might have water aerobics, or even you can even encourage them to walk back and forth in the pools. But handouts, I think, are very helpful, and they can be shared with family members. Watch for mood and anxiety disorders, and physical activity is the best treatment for depression, but also encourage social and intellectual activities, and consider referring for psychotherapy. Again, encourage the sunshine. So overall, the early detection increases the effectiveness of treatments, the opportunities for reversing conditions that may be reversed, and managing and slowing progressive conditions. And the differential diagnosis that you make impacts your treatment and long-term planning, and that's going to be helpful for families, but also for the patient. And keep in mind that treatment is multifactorial, as you just saw from the slides that I realized I kind of zipped through pretty quickly. There are drug treatments, especially for conditions like Alzheimer's, that continue to evolve. So keep those in mind. You may have some of those in your toolkit, and your neurology colleagues may have some additional ones. And don't forget about clinical trials that you can refer your patients to. With regard to planning, you'll want to address need for supervision. I'm real specific or direct in my reports if I think a patient needs supervision and assistance. And I'll tell family members, I already know they're taking care of their loved one, but I say, I'm going to document this so that it can help you in case you need to access resources. Usually I recommend supervision for health maintenance, specifically making and keeping appointments, managing medications, keeping them safe from exploitation or people taking advantage of them, and safety in the kitchen, safety with driving, and we can talk about placement options as well. And I think if you're in primary care, you're probably in a better position to talk about placement options, because you'll know the patient better and have better rapport with them. So caregivers, I always tell the caregivers, you can't take care of your loved one if you get run down and sick. So I encourage seeking respite care, emotional support. I provide emotional support. Primary care doctors or providers that are seeing the patients more regularly can provide emotional support and offer referrals. Social work, our social worker team is amazing, and I think social workers in general do a great job of helping patients access resources. I like to recommend the 36-hour day. It's been around for a long time. They just came out with the 8th edition in the last year, I think, and there is a Spanish translation available too. It hasn't had quite as many editions, but there's a fairly recent edition available. So, oops. Before I go on, are there any questions or comments, or I can see a few faces. No? Rachel, are there any questions? Can you see from the chat?
There's none in the chat so far.
Okay, well then I'll jump into the case presentation. So we've got, this is a woman in her mid-60s, right-handed high school education from the United States. She was referred by her primary care provider due to memory problems. She also has a tremor. She's been followed for that by neurology, and they think it's an essential tremor. They haven't completely ruled out Parkinson's though. So you're going to ask yourself, what are the concerns? What are the differential diagnoses to consider? What do I need to narrow down the differentials? What tests or consultations? Next steps. If there are reversible causes that I'm detecting, what can we do? And this is a hard one. I was thinking about that today. How do we talk about this? Ensuring follow through with referrals and lifestyle changes and recommendations. So, if you're recommending exercise and a regular bed schedule, it's really sad. I see patients back for reevaluation on occasion, and more than on occasion, but because I've been here at this site for almost 10 years. So I've seen, I do see people back. And so often they're still not doing any of the things we talked about. Sometimes they are, but I think the more you loop in family caregivers, so we work so hard to get collaterals in with the patients, so that at least two people are hearing it. And I post my report where they can get to it on my chart, and I'm very concrete in my recommendations. So those are the things I do. It doesn't always work. Sometimes you have family with you that you're not sure if they're going to follow through. Sometimes it seems like they're going to follow through, like in the case I'm going to talk about today. And unfortunately, that hasn't happened in terms of some of the recommendations I'll be showing you in a bit. And then other times, like I had family today with a patient, and I'm pretty certain they're going to follow through. They're already planning to print my report and, show it to mom every time she says, oh, Dr. So-and-so didn't tell me that. But I think when you're in a situation as a family family medicine practitioner or internal medicine, or somebody who's seeing, or psychiatrist or social worker, or somebody who's seeing the patients more frequently, you're in a better position. But be aware that patients don't follow through when they've just heard it once. So you'll want to really stay on top of them and maybe develop some case management services, a social worker, somebody that can follow up to check on patients and whether they're keeping appointments and whether they understand instructions and so on. And then you'll assess response to treatment. You can refer them back for repeat evaluation, checking in with them, watching their labs, their blood pressure, and all those good things. And again, don't forget about the caregiver's needs and staying in touch with them, because that's going to also, how they're doing is going to affect the identified patient. And I will note that occasionally I have concerns about the family member that comes with patients. Sometimes I can't tell who the patient is, or I had one patient I just saw that I've seen a few times over the years. And I noticed that the caregiver was having trouble this time, which I hadn't noticed before. So I think they could benefit from home health to check on how the patient's doing, in part to make sure the caregiver's still able to do the things they were doing, such as medication management. So back to this patient, she's been having difficulties for about 8 months with memory. The onset and decline has been gradual. She forgets to do things, misplaces things, forget things people told her. She might forget recent personal minor events. She sometimes gets lost. She's not reporting any problems with speech or language, although I saw in the note that at one point she had. Now, some patients, I'm real specific. When patients say they have memory problems, I ask these things and I make them kind of yes, no questions. Do you forget to do things? Do you misplace things? Because sometimes what people mean by forgetfulness is I walk into a room and I forget why I'm there. And that I tell people, well, that's a lot of us, that happens to a lot of us, and that's a concentration issue. And you're probably multitasking, you have a lot on your plate, but it's a little different than actually forgetting to pay bills, forgetting to take medication, constantly losing things, forgetting what your doctor told you or your family member. So back to this patient, no visual hallucinations, no REM behavior, walking, talking in her sleep. And no recent falls. And so I've already kind of eliminated diffuse Lewy body dementia. Um, she does have some incontinence, but not very often. And I've already observed her gait. So I've already taken normal pressure hydrocephalus off my list of differentials. And her daughter's denying personality and behavior changes. So frontotemporal dementia behavioral variant is dropping down on that list as well. And the patient's aware of her difficulties, and that's always a good sign. So she doesn't have anosognosia, which really creeps in pretty early in the course of dementia, especially like Alzheimer's. By the time somebody's in the mild to moderate stage, they're not aware. At the mild cognitive impairment, they may be aware, and that may be driving some depression symptoms as well. Medically, she's got high blood pressure. She's had stents, peripheral artery disease. She's had a DVT. She's on anticoagulants, hyperlipidemia, diabetes, chronic kidney disease. So she's the vascular cognitive impairment risk, check, 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 check. She's got those risks. She also has thyroid dysfunction, and if thyroid dysfunction is not managed, or hypothyroidism, that can cause cognitive changes, slowing, fatigue, and depression. She's got GERD. She's had these are just some surgeries she's had. I found incidentally. The right finger amputation, that actually wasn't that long ago, and it was because she didn't manage her medications. She had trouble not just obtaining them, but following instructions. And then she ended up with an infection and had an amputation. She's been diagnosed with sleep apnea, but she didn't follow through with the second step in the evaluation, so she's untreated. But she's denying brain injuries with loss of consciousness. She has had depression in the past. I always want to get past history, because if somebody's in their 60s or their 70s and they're having depression for the first time or delusions for the first time, that's not just, recurrent major depressive disorder or a psychotic condition. It could be a sign of one of the neurodegenerative conditions. If they've had periods of depression where they've been treated over the years, then any depression they have now may be part of that picture. So family history, strokes in multiple paternal relatives, and then also tremor in relatives. So she's at risk for essential tremor, and then she's at the CVAs in multiple paternal relatives. You want to start thinking about different conditions that can lead to strokes. But she just has a lot of risk factors for strokes. And then in terms of psychiatric histories, there are some relatives with bipolar disorder. Nobody's had dementia before age 65 that she's related to. So I'm probably going to drop early onset familial early onset Alzheimer's. So I explained to patients there's really two types of Alzheimer's. There's the early onset that's autosomal dominantly transmitted, and you're at very high risk of getting that 50-50 if your parent has had it. But then there's the Alzheimer's that's a little more common, and that can occur, that usually occurs later in life, and there is some increased risk with genetics, but it's not quite the same as with the familial early onset dementia, Alzheimer's. So habits in this patient, she's got over-the-counter medications. I always ask about over-the-counters, including that she's taking a nighttime cold and flu, and she told me which one, and we looked it up, and it's got an ingredient that has anticholinergic properties. So she's taking that kind of frequently. Caffeine is semi-regular, and caffeine and coffee are not a bad thing as long as it's not contraindicated, like with her high blood pressure. I usually ask about caffeine because I want to know if people are self-medicating because they're tired or having trouble concentrating. She quit smoking, so that's a good thing. She's not a heavy drinker. She did drink a little heavier before. I didn't ask the size of the bottle. A bottle can be pretty little, and so that wouldn't be too bad per week. But if it's a large bottle, that might have been heavy. But the important thing is she's not drinking now. She has used uppers in the past, so that could have contributed to some cerebrovascular changes that we'll see in a minute. But she's not using drugs right now, so that's good. She has poor sleep hygiene, irregular bed schedule, sometimes up all night and sleeps during the day. She did previously work nights, so that probably contributed. We already know that she's been diagnosed with sleep apnea and she continues to have symptoms, but no REM behavior. So again, we're gonna, another reason to drop off the Lewy body dementia from our concerns. She's not really exercising very much. As far as her ADLs, she's independent. She feeds herself, goes to the bathroom herself, dresses, undresses, bathes, does her grooming and hygiene. She's preparing simple meals. She grocery shops with her daughter, picks out her items, and sometimes also makes the transactions. She's doing laundry, dishes, tidying the house. She's driving some. I always ask if they've had any accidents in the last 2 years because people who are developing dementia or have dementia are increased risk of accidents. So that can be telling. She is getting help with paying her bills because she was forgetting. She's managing her own medications. She gets the prepackaged medications, but still sometimes forgets them. And the other problem with the prepacked medications is she has to be oriented to time and date to know when to take those and not lose them. She also has help making appointments because she's been forgetting. So basic ADLs, okay, she's needing some help with her instrumental activity of daily living. Relevant labs, her B12 is good. Her A1C isn't great, but for somebody with diabetes, the physicians in this group might feel like that's not too bad, and we've all seen much, much worse. We can take syphilis, neurosyphilis off the differentials. Her treponemal CIA was non-reactive. Here's where we get to the big deal. Her thyroid stimulating hormone has been all over the place and quite elevated, and sometimes the T3 and free T4 have been off as well. So we're worried about thyroid dysfunction contributing to some of her symptoms. So she already had brain imaging by the time I saw her, and she's got some mild volume loss. And she's also got indications of cerebrovascular changes. She additionally has loss of the swallowtail appearance in the substantia nigra, which can be an indication of Parkinson's, loss of the dopaminergic neurons. And that hadn't completely fallen off the differentials for neurology for her tremor, but you want to keep in mind that thyroid dysfunction can also cause loss of those dopaminergic neurons as well. And you just saw that her thyroid is not functioning so well, or her thyroid functions are off. So here's her brain imaging. I try to get a close-up of the loss of the swallowtail. This is what it should look like. And this is what she has. And it's not a great slice, but I just want to give you an idea of what the radiologist was talking about. So neuropsychologically, she wasn't so bad. She had some difficulties with her visual constructional drawing. So we give them a complex figure to copy, and there was a lot of disorganization. And then she had some difficulty with list learning, but story memory was good. She did endorse a lot of depression, and she attributed that to stressors. So some of her stressors include her retirement, which can have a big impact on people. They become less active, and they just lose their purpose, their meaning in life. I didn't see any tremors. She didn't have any masked faces. Her gait was normal, and as I noted, she's not having falls. And I don't say it here, but I would have noticed if she had a lot of difficulty standing up. And gait again was normal. She was noted to have some trouble with hearing, and if you can't hear, you can't remember. But at the same time, people with Alzheimer's are at risk for hearing loss just because of where the neurofibrillary tangles and plaques are. The abnormal pathology in the brain can also be affecting hearing. So my conclusions with this patient were that she had poor concentration. We have to come up with a diagnosis when we're seeing patients and we're billing insurance, but she did have poor concentration. She has subjective memory complaints. I diagnosed an adjustment disorder with depressed mood, but I can't entirely rule out mild cognitive impairment because she did have some problems with rote verbal memory and the drawings. And so I also can't rule out early stage dementia of the Alzheimer's type. Risk factors. She obviously has thyroid dysfunction. That's a major risk factor. Her untreated sleep apnea is really concerning. And I talk about this at length when I have patients. And I talked about in front of the daughter. And I really thought they were going to follow up with the sleep clinic, and they haven't so far. Multiple cerebrovascular risk factors for vascular cognitive impairment. And then she's got the nighttime cold and flu. So there are a lot of things she can reverse and turn around and get improvements in. And she has the depression, which can cause concentration problems. And depression can be treatable. So she has the potential to experience some improvement, no matter what underlying conditions she might have. And then, as I know, the hearing loss is a risk factor, but it goes both ways. There's a complicated relationship between dementia and hearing. So the next steps are repeat neuropsych eval can be done at any time. If a person, she's only had about a year decline, so I would say 6 months to a year because we're getting her pretty early. If it's definitely a rapid decline, I'll see them back even sooner, 3 months, to see if I can pick up any change that might be helpful for clarifying the diagnosis. It's possible now to order phospho-tau 217. It's a blood test to look for the biomarkers of Alzheimer's, but I would consider the ethical issues and ramifications of doing that, and discussing that with the patient at length before you make that step. I encouraged her to follow up with the sleep clinic. I gave them the phone number and remind the family member and the patient, call. You need this other appointment. I talked to them about the risk of sleep apnea. And we talked a lot about sleep hygiene, and this is something all of us can do with our patients. Again, decreasing our time in bed to no more than 9 hours, ideally a little bit less. Develop a routine at night and a regular bed schedule and a routine in the morning. During the day, I encourage her to limit her naps. I'll tell people, if you really need to take a nap, make it 20 or 30 minutes top, but set an alarm and set the alarm away from you. So like if you're going to set an alarm on your phone, put your phone across the room because it's so easy. It feels so nice to be sleeping. It's real easy to hit snooze or off and keep sleeping. So I'll tell them to put the alarm on the other side of the room. And then also when she feels sleepy, going outside and getting sunshine and some physical activity can improve her alertness. I also encouraged her to not take over-the-counter medications without checking with her doctors or pharmacists. Specifically ask, like if she goes to the pharmacist, say, what can I take that won't, cause memory problems or sedation? And then I encouraged exercise, and I usually look in their record to make sure nobody's told them not to exercise. And I've yet to see that. But a lot of times I can say, follow your doctor's recommendations. They told you to exercise this many times a week and this long. And I'll show them chair exercise videos and say, show these to your providers to make sure they're good with you. And I'll give them information about here we have Dallas Parks and Recreation. Wherever you are, your recreation centers may have some gyms or activities or classes, which are always good. I encouraged her to increase her social and intellectual activities since she retired, and that's really impacted her negatively with her mood and her sense of self-worth. We talked about volunteer opportunities, the Parks and Recreation. If I know my patient's religious, we'll talk about activities at their church that they might do. And I referred her for behavioral health services to address her depression. I also referred her to audiology. And some of your patients may have hearing loss and they may not be able to afford hearing aids. And I just remind people that now you can get hearing aids without a prescription. And I pull up Amazon. You'd be amazed what people can get for their hearing on Amazon for pretty inexpensive. Little rechargeable personal amplifiers. And they can show them to the audiologist. And I've noticed in audiology's notes now they're informing patients of these kinds of options as well. I encourage everybody that works with the patient to give her instructions in writing, not just orally, since she might forget them if she's not concentrating. And instructions should be really concrete, direct. How many of this, how often to do this, how long, what to do. And I encouraged her to give her daughter access to her patient portal, where she can also interact with providers if there are any questions about, well, now how is she supposed to be taking this levothyroxine, or when is she supposed to take it, what dosage? The family members can help keep track of appointments and prescriptions as well. I also talked to her about reminding herself to take her medications by setting or repeating alarm in her phone app, her phone's clock app. And sometimes I'll set the alarm if the patient gives me permission, we'll set it together. Or if they have a family member who's tech savvy, I'll ask them to do it for them. And again, I encouraged them to look at the notes. I saw endocrinology had some notes with real specific instructions. And I felt like for her, a pill organizer would be more beneficial. With my patients that are particularly impaired, if they don't have somebody living with them, I'll show them the pill dispensers online that are, I have a coworker who had an aunt they thought she had dementia. She was experiencing delirium because she was messing up her medications, and they got one of these dispensers for her. If you just Google or go into Amazon and put in locking automatic pill dispenser, some of them are even Wi-Fi enabled, but the wheel rotates on its own and it deposits the pills into a little slot, and then the patient pushes a little lever and the pills come out, and there's an alarm and a clock. And with my coworker, his aunt was cured. So that made all the difference. So they can be they're a little more expensive. The least expensive ones are close to $60, and they range up to a couple hundred when they have a lot of bells and whistles. So not everybody can afford that. The pill organizers, the monthly, twice daily, you can find some for under $20. And hopefully the patients are able to afford those. Some clinics will hand those out. We have some here, the weekly pill organizers. They cut me off in my clinic though, because I was giving away too many. But that's something to think about with a lot of your patients. And here are some resources. TexasCaregivers.org is a great website. I love it because I have the name of the website memorized. It's a really handy name, but it has all kinds of information about respite care. This site here is another one offered by the state, and family members can look for facilities like skilled nursing facilities and assisted living. And then I like to refer people to the local chapter of the Alzheimer's Association, and they can go to this alzheimers.org, and then on that page they can find something nearby for their locale. And then this is txalls.org/caregivers. And I explain to people that these latter websites, you don't have to have Alzheimer's. I don't know if your loved one has Alzheimer's, they have dementia, or they're having this problem, but it's vascular, but the information on these websites is still helpful. And as I said before, the book, The 36-Hour Day, is really nice. And I like referring people to social work because they're really helpful, helping patients access resources and applying for funding. Let me see if there we go. Are there any questions or comments, or other people have any ideas about how you manage some of these? If you have ideas on how to get patients to follow through, that to me, that's so hard. And I've heard providers in other disciplines, not with dementia, but like with our epilepsy patients, sometimes the providers give up because they know the patients aren't going to follow through with certain recommendations. And it is. So it's not just in dementia care, it's across the board. If anybody has ideas you'd like to discuss or share.
I just had a question for kind of rural West Texas. When you say to refer to social work, the clinic is just me and my husband. The other clinic also doesn't have a social care person at all. Is there something centralized for Medicare that we need to be aware of?
Yeah, I would go to, there's one site I don't have here. Well, one that I give out here, but it's the NCT, North Central Texas Aging and Disability Resource Center. So you might want to, whichever is your closest urban area, city, see what they have in terms of aging and disability resources. And the state's also going to have, I'm trying to think of the website. I should have had that ready for you, but the state has Department of Aging and Disability. It used to be called DADS. But you know how the state of Texas likes to reorganize all the time. But this Texas HH Health and Human Services does have a lot of resources, so you might want to even start there. But try these first 4 websites. Well, especially TexasCaregivers.org. They may have links to social work, and the Alzheimer's Association and TexasAlzheimer's.org's caregivers.
And Dr. Molina, we do have Erin Baker. She's on the call, and she's with the Garrison Institute on Aging. So if you want to send me your contact information, I can connect you with her as well.
Great, thank you.
And you can feel free to email me. I don't know if my email address is available to you. It's really easy. It's leslie.rosenstein@utsouthwestern.edu. Not easy to type, but and I can talk to our social work team. We have a great social worker here, Luis Moreno, that I rely on very heavily, and if anybody's going to know what's in your area, he'll know. So if you let me know your location, he might be able to find something.
Great. I'm just going to put it in the chat for you and for Rachel too. And that would be wonderful. All help is greatly appreciated.
I do send out a thank you email, so I can include your contact information, Dr. Rosenstein, in the email.
Okay, great. Thank you.
Please
And
feel free to unmute yourselves if you do have any questions for Dr. Rosenstein.
while you all are thinking of if you have questions, I don't know if there, oh, I was supposed to show this too. So I have this up here, but I'm gonna, after you get a second, I'll scroll down to the test scores. I don't know if there are any psychologists in attendance. And I will tell you, in case there are, I always include test scores at the end of my report. My patient has access to it and their providers get it. So if the patient moves, they have my report and they have those test scores. And so if they have a repeat evaluation, those test scores are there to compare to. And let me just show you in case you're interested. This was in the report. I reformatted a little bit for the slide, but you can see like this is where she had trouble, a little bit of trouble with the list learning. Story memory's normal. Her visual, even though she had trouble copying that figure, her memory for it was good. Language is good. Word generation speed, really good. Intellectual functioning is normal. This is her general fund of factual knowledge in the normal range. Nonverbal reasoning and pattern, that's like natural intelligence. Span of attention, backward, this is forward digit repetition, backward digits. Her visual scanning speed is normal. She had some trouble here dividing her attention, but she improved. Once we redid it because she just got stumped at one point. She's seeing things for what they are. Her clock was okay. This is a test of planning and abstract reasoning, affect perception. She had a little bit of trouble with, and that can be that's one of those signal things. And then this is her depression score. This is a really high score on the Beck Depression Inventory. And I'll go back to this. Rachel, did anybody have any more questions?
Not seeing anything in the chat, but thank you so much, Dr. Rosenstein. That was a great presentation.
Oh, thank you. I feel like I talk when I can't see people's faces, I don't, and I can only see a few at a time. I don't know if I'm clear, if people are understanding. So if there's any, ask if there's anything I went through too fast or you have questions about.
Dr. Rosenstein, quick question. This is Ariel Santos. I'm the Texla project PI, sorry, principal investigator. Do you usually share this as well with their caregivers, with their family members to see the trajectory of the patient and how they're doing?
Yeah, you mean the test scores?
Test score, yes, yes, ma'am.
Yes, they're in my report, which is posted to, I'm in a large center, we use Epic. So it's on their medical record and they can access it through MyChart. I used to mail reports to people, but I was really getting concerned because I had a patient once tell me, oh, it came in the mail and was opened. So I worry about patient privacy, but I make sure, I go through it and sometimes this is one thing I didn't mention. Sometimes I have patients that they come with a family member and they're not using MyChart yet. And with the patient's permission, I get them signed up for MyChart. We get their user ID set up and their password so that then the family can access the report. So yeah, especially if family members are there, I definitely point them in the direction of the scores. And I do share the scores with them during the appointment and I let them know that those scores are there so they can be followed over time. Is
Yeah, I
that
think that's a great idea. Thank you very much and excellent presentation. I think this will be the last of this series, Rachel, right?
Yes, correct.
And so, yeah, well, I don't know if you have a parting word, Rachel, or the team, but thank you very much for guys, all the cohorts for attending and, this partnership with Garrison Institute of, Garrison Institute for Aging, Dr. Singer, thank you very much for the support and the collaborations that we are doing, in behalf of the uh, Department of Health for the state of Texas.
Yes, thank you once again to all our participants as well. I did notice that y'all are having some issues with the QR code. Was anybody able to download the handout? There is a link in there and the link is working for me. If you have any issues, just let me know, and I can see what I can do about that, but I will send out the handouts as well in the thank you email, so. But thank you everybody once again for participation. Just a reminder, we do have the post-session survey and then a post-series survey. So please complete those for us, and that kind of helps us prepare for the next coming year. So thank you so much, Dr. Rosenstein, again.
Thank you for having me. I appreciate it.
Yes, thank you.
And great job, Rachel. You did a great job for us this year. So thank you very much, and Kelly.
Thank you, Dr. Santos. Everybody have a good afternoon.